A little bit about our presenters here today. We have Lisa on, who is the CEO of Pembina County Memorial Hospital Association in Cavalier, North Dakota, and she's been in that role since 2017. Disclosure that both presenters have indicated that this presentation will not include discussion of any commercial products or services and will not include any discussion of off-label and or investigational uses of any product or services and will not include trade names. Also, please note that you can go ahead and type in questions into the chat box, and if time allows at the end of our session, we'll answer those questions. Otherwise, feel free to email those questions to Amy Breidenzer here on the platform, and she'll be able to get those questions passed on to our presenters.
So when I was asked to do this kind of about our community needs assessment that we had done in 2020, so obviously I lost my partner in crime here, so kind of some things that changed for us as we did it. There were no in-person meetings. All responses were gathered via survey. Surveys obviously are phone interviews, so a lot of more communication done via computer or email, telephone, that way, kind of dedicating a person to make those calls and touch out with people. Group meetings were virtually with the committee, which was a lot of, obviously, technology glitches here and there with COVID and stuff. And then limited resources and time constraints, of course, because with COVID and stuff, that kind of made everyone's schedule a little bit difficult, but in getting it done. Identified needs, these were what we had identified again. And in years past, looking back, it always seems like it was kind of a revolving door of some of the same things, but ultimately with the same themes. So mental health was a huge one. Alcohol, anything from alcohol to depression to bullying, as you can see, all those aspects. And then the other things. And some of the others, of course, being a critical access hospital, having to partner with individuals and talk with your city leaders and public health and talking through them with some of these ideas. And sometimes just individuals not knowing what is available in their surrounding area. So we then chose to hit mental health hardcore with this. So we hired a psychiatric nurse practitioner to work in our clinic. She's been developing programs to help serve the individuals that we see. We then took another step forward and hired a spiritual grief specialist to help develop the programs. Programs such as craft, mental health, first aid, and then we had added another instructor on as well. So our employee resource specialist is actually now a mental health first aid instructor as well for both youth and adults, and trying to reach out. Our public health and us had kind of collaborated with all the different health organizations within our county and developed a behavioral health coalition. And from that behavioral health coalition, we were putting on events like speakings and having like Frank White from the University of North Dakota come in, and he did some talks on vaping and bullying and drug use and abuse. We did a program as well, a video uptown, and held all the resources that are available that way. But and then we did a lot of kids events at the school with behavioral health and different entities and ran them through kind of mock scenarios. But with COVID, the Behavioral Health Coalition had kind of went dormant because public health had spearheaded that, and they still hadn't been able to put that live again. So we have started that back up and are now leading that and rebuilding that. We went a step further and did a book just entitled Pembina County Behavioral Health Resource Guide. So we have a resource guide for our whole community that we had built, and it resources from anything if you need food to housing to water, any of that. So then we decided that behavioral health needed its own. So now we've printed that and are dispersing that and put in a med-safe deposit box in our clinic. So mental health, as you could tell, was a huge focus, not only on our community needs, but something that we took huge steps in. Some other services to meet the community needs assessments, things that came out of it was we began a bone builders program for ages 60 and up. They wanted to have resources available to help the elderly stay in their homes longer. So our physical therapy department developed this program to help our individuals that we serve that are 60 and up free of charge. We did receive a grant as well to help with this piece of it. And are seeing good participation in it, and the individuals that are doing it are having fun, and plus learning to maintaining their physical activity can support them in staying in their homes longer. We continue to support the Cavlandic Bike Share program in ways to attract and retain young families and also increase physical activity. What that is a bike program that we actually have bikes at Cavalier, in the city of Cavalier, and then at the park, Icelandic State Park. And so individuals can rent the bikes and go back and forth between the two entities or around the town or whatever. And there's also a bike path that actually is the whole 5.5 miles from Cavalier to the Icelandic State Park. So they get to use that. And it was just repaved last year, so taking full advantage of that, especially during the COVID crisis here. We are currently in the plan of researching a facility-owned daycare for our staff. We are finding that to be a huge issue, and some other entities have done that as well. We just had another local daycare close, and 2 more in a surrounding town. So definitely are seeing the issues there with needing daycare for our staff. We've been lucky enough to maintain or recruit a young staff. So with that comes obviously different issues that we've never had before. Optometry services. Currently our optometrist had left about 7 years now, and we've been trying to look at different avenues for that piece of it. So we'll be joining with our city council and city groups to kind of work on that piece. Help and help ourselves also, and as well obtain the services for the area. We've hired additional staff for rehabilitation services. Again, that goes hand in hand kind of with that, maintaining individuals in their homes, also being able to get people rehab quicker and then back out to our community. Of course, it wouldn't be possible without a great staff in collaboration with the University of North Dakota Center for Rural Health. They are instrumental in helping everyone through their community needs assessment if they need help, and their staff is wonderful to work with. And that, I think, is all I have. I was kind of hoping Marianne would be on here to help us, but Nicole, do you get over here and see if she's on or questions?
Yeah, I think what we'll do at this time is we can open it up for questions or just general discussion. If someone has a comment, we can go ahead and unmute you if you just want to. Let's see, raise a hand here. Let's see. Brad, I see you have your hand raised. Let me. Or not. Maybe he unraised his hand.
You get to see the wonderful weather I'm seeing out here.
I did add Brad to the stage. So Brad, if you turn your camera and your microphone on, you should be able to participate.
Okay, so now can you hear me?
Well, Pete wants to know how I found a nurse practitioner in St.
Yeah, a little bit about that process. And well, anyway, just deal with that question first, Lisa.
I guess, she kind of just fell into our lap. We were it was looking, kind of researching the idea and then looking at it. And then she came up for a visit and she loved it and stayed.
Good.
Crazy how that works, but I'll turn off my mic or my camera. I think it creates feedback maybe. But yeah, she is a single individual and is loving the opportunity to grow a program in a small area.
I guess the other question I would have is, I don't know, but I'm guessing you started this without any grant assistance. So basically the hospital decided to invest in this. Are you anticipating that through reimbursement, you'll be able to have enough financial support to support the program?
Yeah, so it kind of took off just crazy too. And the Northeast Human Services, as you know, has been cutting back services, and Dr. Hill retired. So he has transferred all of his Pembina County patients to us. So it grew, huge right now. So yeah, it's crazy.
Okay. Another thing in this area, and whatever I'm going to say on this totally exhausts everything I know about the subject, and I only got a couple of comments, but I sat at NRHA, I sat in on not so much a session, but end of the day discussion, and Ralph Llewellyn was part of this. And I'd also mentioned this to Nicole. One of the things that Ralph talked about was he seems to be interested in the idea of outpatient psych departments as an idea that can work in critical access hospitals. From a payment perspective, you wouldn't have to employ a psychiatrist or a psychologist, but you could contract with somebody. But he saw it as it seemed like it was sounding like a legitimate option to look at from a payment model. So if you haven't, you may want to give Ralph a call and find out more about that.
Okay. Could you send him, Brad, could you send me his contact information?
Sure can.
That'd be great. Yeah, right now, she's just based in our rural health clinic. We haven't, obviously they send her, consults obviously from the ER and, referrals to her from the ER and stuff. But I think staffing, that is what I foresee, in a critical access hospital. If we were to put services inside, inpatient or, in the hospital, that's the huge thing is staffing that.
Yeah. Yeah, what he's talking about is strictly outpatient. So
okay, that would be good.
Yeah, it's not an inpatient model; it's an outpatient model.
Good.
But it might be something, and I'll get you contact for Ralph.
Awesome.
It's great. I'm really glad you're doing this. There's a couple other hospitals that are in the game, so to speak, relative to like a psychiatric nurse practitioner. So. You guys are leading on there, and there he is. There is Ralph. So
hi, Ralph.
I teed this up nicely for you, sir.
You did good work. You did really good work. So
I do really well when I don't know things.
All right. So here's the model, and I'm a huge fan of it. It started mostly in maybe the lower Midwest part of the country, but it's a geriatric psych program, and it really has to focus on geriatric psych to work. It really starts to break down if you do otherwise. And basically the way it's functioned is it's 100% Medicare if it's done right. And so as you encounter expenses, you're typically pulling expenses away from other areas in your CAH that are not 100% cost-based or maybe not cost-based at all. And so I've seen programs, I was just doing one, I got a webinar I'm doing next week with a piece on this, where you maybe incur, let's say $300,000. That's not the right number. It'll be probably higher than that. But when you figure out the $300,000 you incur, you end up improving your cost-based reimbursement by, let's say, $450,000, because you're pulling costs through the overhead allocations away from a low Medicare utilization or a no Medicare cost-based utilization into 100% arena. And everyone I've ever looked at, and most of the people that do this use a couple different companies in the country that help you. They help set up the programming. They help you get the providers. That some of it's remote. It's just a really interesting model that with all the attention to Jerry psych or psych in general, it makes a lot of sense. If you start letting you expand that into other payers, commercial and Medicaid, the benefit really starts to fall apart quickly. It does not have an inpatient component when it's been done correctly. If you're doing an inpatient, you can do a 10-bed unit, but that's paid under a PPS methodology, prospective payment, and that reimbursement really does not play well. You need to have an average daily census of around 7, maybe even a little more than that, and with a cap at 10, you really can't get to an average of 7 or 8. You're going to be lucky if you can get to about 5. So definitely something if people are looking to explore something like that, help with the analysis and help people look what it can look like, look at it from a strategy perspective of even what parts of the hospital footprint you'd be looking at.
All right, thank you, Ralph. I think we might have had Lisa drop off with her connection. I do see it had posted in the chat a question concerning a continued stigma around mental health, and if Lisa had seen any resistance to seeking care locally and how she might have handled that if it was a hurdle. So we'll make sure, Pete, to send that on to Lisa afterwards if we aren't able to have her connect in. We have about 10 more minutes here in our session yet. So other thoughts or questions that the group would like to pose, and we can unmute others as well. If you go ahead and raise your hand, we'd be happy to help, again, just facilitate some discussion around CHNAs, your implementation ideas, maybe thinking outside the box. Many facilities have been through several rounds of CHNAs. I'd be curious to see if anyone has lessons learned, maybe things that as you've completed several in a row, maybe there's been something that you have learned along the way, become more, things like that. So we're going to add back in Brad. Oh, here's Lisa as well. Lisa, are you able to hear us?
I am. Sorry, everything just went kabooey again.
Let Lisa address Pete's question.
You know what? I think she just popped off again.
Oh, shoot.
So I'm not able to see her.
I'm right here, so I'm good.
Oh,
I can hear, if you can hear me. So
Yep.
in answering Pete's question about is it local, I will say having, because mental health is such a touchy area, but I thought we would actually have more issues with it being local and resistance to it. But honestly, people, there is a certain clientele that like telehealth or telemedicine or, that piece of it. Then there's a lot of clients that have said, nope, they like it. And I think it took a while for the patients to get used to the provider and the provider to get used to the clientele of that area. I think all areas will have a different kind of focus maybe when it comes to psychiatry, especially and mental health, whether it's addictions or depression or, what kind of stigma. And I think too, she brings a lot of knowledge to our providers as far as when patients are coming in and wanting more, say, benzodiazepines or antidepressants, and just how those all work together. So I think we have a really good buy-in from our providers, and that's probably a strong piece that is led to the success of the program.
Another thing just to mention too, as we're talking about implementation ideas and things like that for your CHNA, if you haven't been aware, the CRH had a quick round of funding that was available here this spring for some CHNA implementation work. And so that was kind of a first step in that direction, but it's something that the Center for Rural Health anticipates coming up with our new grant years as they turn over here this summer and fall. And so be aware of that. There's smaller dollars that are available to help kind of give that boost to something that might be in your plan and just hasn't been able to been started yet. So if you have any questions on that, feel free to reach out to either Nissen or myself, and we're able to help give more information on when those programs might be coming available. But just a good idea to keep. Brad, go ahead.
Okay. Just a thought. One of the things that we talk a lot about at the Center for Rural Health, and I don't think we've had a lot of success with this, is that when hospitals and communities are involved with their CHNA and really going into the implementation process, to pay attention to what other communities are doing, and if they're doing something in the same family of ideas that you are, you may want to see if there's a way that you can work together and kind of network. Even with this new, seemingly new development of hospitals looking at having a psych nurse practitioner. You know, you would, one thing you may want to think about is you obviously have to maintain your own program, your own services within your community, but you still may want to look at some of those other towns that are basically at the same point in time that you are, and go, are there some things that we can do to collaborate? You know, there may be a way to, you know, develop a common education program that could be used in 3 or 4 towns. There may be a way, particularly with telehealth, to, if somebody is on vacation, that you can back up those services with a nurse practitioner in another community. I think there's probably a lot of ideas that could be looked at. So those are some things that I would put out on the table for you to think about. And if you want us to help you think about them, we're more than interested in doing that. And we'd also be willing to try to find a little bit of extra money to help do that. So, but again, I would say if you're on this path right now, you obviously, number one, have to take care of the home fort first. But if there is a way to increase services, access, whatever, by talking and collaborating, that's obviously a good thing to think about. So that's my comment.
Another comment to play out that too, Brad, is just a reminder out on the Center for Rural Health's website, if you're curious to see what other communities are working on or what their identified needs are, you're able to see that information out on the Center for Rural Health's website and the results from their community health needs assessment. So if you're looking for similar needs, that's a great place to start to see who some possible partners could be for collaboration. So definitely encourage everyone to check that out as well. All right, we have a few more minutes here along our course of time. We're set to be together until 4:10. So any other questions, hands you want to get raised on different ideas? I started posing the question if anyone's observed how they've evolved over their CHNA years and different processes. I've been part of things on the local level, and I feel that we've, being part of that over multiple efforts, our processes have changed, lessons learned and things like that. I want to pose that as well to see if anyone has observations on how they've streamlined, improved, or had some great aha moments maybe over the courses of doing multiple CHNAs.
This is my, I think, second one in my position I'm in currently. But prior to that, as being a part of it is making sure that you get everyone on deck, like everyone knows about it, making it your own, because that was kind of something that, at first it was kind of like, oh, you get this blank template, it's just easy to use it. But then now that we've been able to be, hey, let's switch this or change that, I think that's helped greatly to get more out of it, what you actually want versus, what does the community think we need, or what do they see, or what don't they know about? So.
Right. Thanks, Lisa, for that. And it can kind of almost be viewed in 2 sections of the process too. Of course, there's several steps and things like that, but the CHNA portion that leads up to getting your results and then developing your implementation plan and ideas that surround it. Having partners all along the way is very important, like Lisa said, and moving from your results into your implementation plan. So just something to bring about as well.